Dr. Chan and Dr. Susan for help with this talk. Okay, so let's get right in it. You saw the initial slide. This is the triage note. This is a 36-year-old female who has bloody vomit, tarry stool times 1 day. Those are her initial vitals when she first presented to the ER. So the age of the patient, she's 36 years old, had a history of recent lap band surgery, lap band removal surgery maybe 7 months prior to this incident. Also a recent discharge from an outside hospital from upper GI bleed, who then presented to us after multiple episodes of vomiting blood at home today, or that day, sorry, and 1 episode of black stool. She also reported having a syncopal episode the day before. Of note, when she had this upper GI bleed at this outside hospital, they did an EGD. She had multiple transfusions at the time, but had negative EGD. They actually never saw any active bleeding, just stable clots. So she's here with us now in the ER. So review of systems, like I said, she's actively vomiting blood as we're talking to her. She does say that she's had no chest pain, which is important because she had the syncopal episode. So no chest pain, no shortness of breath, no recent travel. She's not on any birth control or anything like that if you really care about that at this point. No sick contacts and hadn't had any trauma. Past medical history, she was an obese young woman who had lap band surgery in 2010 and had to have it removed 5 years later due to complications. The complication was erosion of the lap band. She also takes no other medications, and I guess now that we know she had this episode of upper GI bleed a couple of days ago, upper GI bleed is also in her history. Takes no medication, social history and family history are non-contributory. So, you have a patient that looks like this in front of you. What do you want to do? Okay. So initial steps to ABCs, of course, her airway is patent. She's vomiting out of it, but it's patent. She's breathing. She was tachypnic though. Circulation, she's tachycardic and had a very faint pulse at this time. And I threw mental status in there because you're looking at her and you can't miss it. She's getting lethargic. So what do you want to do next with this woman that's bleeding out of her mouth and so initial interventions, this is what we did. IVO2 monitor, right? She came in with the right EJ by EMS. She got the oxygen, the nurses are setting up the monitor, and we're setting up for airway. The patient got intubated for airway protection. Someone ran for massive transfusion protocol. We got the IVs going, we got the fluid going, all right? So now that we've done the initial interventions and the patient is at least somewhat taken care of, we're going to do a physical exam. These are her vitals. As they were put up as you're intubating, these are the vitals that you get. This pulse actually might be a little lower. This is what was documented, but it might be actually a little higher for this patient, right? Her heart rate is like 70 over 55, so I'd expect her to even be as high as 140 even could be as possible. And this respiratory rate could be higher as well. But regardless, she's in shock, right?
Not good.
So the rest of the physical exam, she's ill-appearing, she's somnolent, HEMT exam, no trauma, her extraocular exam is normal, she's got pale conjunctive and pale mucosa, and she's vomiting frank blood. Cardiovascular exam, she's tachycardic, otherwise the rest of the exam is normal. Chest cleared auscultation, abdomen. She complains of just some mild left abdominal tenderness, otherwise no rebound, no guarding, and her bowel sounds are normal. Rectal exam, which was done, she has melena, but no blood in the rectum. Her extremities, she moves all 4, no edema, no calf swelling, no tenderness. All right, skin is clear, but like I said, she looks pale. All right. So let's make a differential diagnosis. Sorry, we'll reassess the patient, right? So she's intubated, she's assist control, those are her settings. Pretty minimal, because airway was never, respiration is not her issue, right? She's responsive to IV fluids so far. She got a liter, massive transfusion protocol was started. She got 4 FFP and 4 packed red blood cells in the ER. And the repeat vitals actually look pretty good for someone that just kind of, crashed in front of us. She's still a little tachycardic, still about this a little bit. This is one of the prediction scores that is used in upper GI bleeding. Okay. All right, so this is the differential diagnosis I had with the patient. I mean, there's a lot of other things that you can include on this list, but just with the patient that we're looking at, the past medical history she has, this seems like an appropriate history for us. These would be the most likely. She had a history of a bleeding peptic ulcer in the past, so most likely what it is, might have some gastric, erosive gastritis. Maybe it's a variceal bleed, we don't know. She doesn't have a history of alcohol abuse, but maybe she has
Didn't you say she just had a clean EKG last week though?
So she did, but she had to be transfused multiple times, and yes.
The EKG showed ulcers,
But
it was
not
not
active
active ulcer extension, it just wasn't actively bleeding at the time that she was stroking. But she had.
And there's a bunch of clot.
So we didn't have to report, so
Where was she tender in her belly?
left lower abdomen. So according to the. Okay. We're gonna have time for a few more questions later, don't worry. Okay, so let's make a preliminary problem list for this patient. Just the four major things that you're worried about in this patient.
Bleeding.
Okay. Shock, bleeding. All right. So we already controlled the airway, so that was the first thing. We controlled that already. She's in shock. Definitely, we want to take care of that. Hypertension is one of them, and she has a GI, very broad, but very encompasses everything that's going on with this patient. All right. So further testing that this patient got, she got an EKG, which was normal. This was important because she had this syncopal episode. She got a chest X-ray, basic labs. Basic lab including shock, PT, PTT, and then we got our consults, GI surgery and MICU are sort of the standard panel for this type of patient. So let's go over the results. So ETH level was negative. Only I highlighted the things that were important. The hemoglobin on here, her hemoglobin was 5. pH for her was 7.29. Her lactate was 3.8. And then this is the CDC coaxial K. The reason I highlighted lactate, in upper GI bleed patients, lactate is elevated. What does this mean? In the literature, trauma patients, usually a lactate about 4 is significant, was suggestive of hemorrhagic shock. So I went to look to see if there was any numbers for upper GI bleed patients, and an article I found said a lactate of about 2.1 was suggestive of hemorrhagic shock, but very low specificity. So when a lactate so hers is 3.8, so if it's like 1 point higher than this 2.1, but the predictive value of a lactate in a bleeding patient with hemorrhagic shock is actually better when combined with the Rockwell score. So this patient's Rockwell score was 5. We're going to talk next about what exactly does this Rockwell score mean. So, all right. So there's actually 2 predictive scores that you can use. One is called the Glasgow-Blatchford score. This is actually on Med Health, and then the Rockwell score. The Glasgow-Blatchford, I'm going to call it the GBS score. So the GBS is actually not very useful to us. This is a low, it's used in low-risk patients, stratifying who can be managed outpatient. So definitely not something that is going to be useful to us. The criteria that they use in the score, lab results actually. So they use BUN levels, hemoglobin, patient's comorbidity, so do they have heart failure or not, hepatic disease. So all the things that you think about when you're looking at a critical patient with an upper GI bleed. Also, they consider I mentioned the hemoglobin level and whether a patient has an active bleed or not. So the way this score is managed, if a patient has a score greater than 0, so if anything on that score is positive, this is a high-risk patient, which means they need a medical intervention. So any patient that we would see in the ER, if someone shows up complaining with melanoma, they're already high risk, right? They're not going to see this patient in the clinic, so this is sort of not that valuable to us in the ER. The Rockwell score is actually more useful to us. It's a score that's used to assess the mortality risks in patients with active upper GI bleeds, mortality as well as the bleeding risk. So it uses, it doesn't actually wait for you to use blood test levels because we don't have time for that in the ER. So they use the patient's age, they use the patient's The patient's age, whether or not the patient is in shock, is in active bleed, and the patient's comorbidities. So the same thing, CHF versus liver disease, things like that. And then they calculate the score. It has a max of about 20, and then they give you the mortality based on the score. So I told you our patient had a Rockwell score of 5, and this is sort of how it's broken down. Greater than 3 is a 5% mortality, greater than 4, which is the class that our patient would fall in, 10 to 25%, and then greater than 7 is 10 to 35. I just have a table here that just kind of shows you how the Rockwell score looks. So this is the A score of 0. She was less than 60, so she got 0 for the age. And then for shock, she was definitely less than 100, so she got 2 points. And you kind of go, she had other diagnoses. We'll say maybe this GERD upper GI bleed gives her a point, and then she had an active bleed, so she ended up with 5 points. That's how I got that for her. This is her chest x-ray. Does anyone want to tell me what they see on the x-ray? This section. What's on the x-ray top? Okay, it's a normal x-ray. And you can just see the tube, right? The patient was intubated. So I only learned this when I was in NICU, so that's why I thought it was important. You know, the nurses will always ask you, is the tube in place? Is the tube in place? You always want to make sure the tube is below the top. So it is. Might be a little low, but so we find problem list for this patient. Hemorrhagic shock or hypovolemic shock versus massive upper GI bleed. Okay, so we've looked at the lab, we've looked at the imaging that the patient got. Now let's see what our consult said. They came and saw the patient very quickly, right? Because you called them and said, come now. GI was the first one to get there, surprisingly. They said it's a massive GI bleed, massive transfusion to a goal of 10. Started PPI, we're going to do the EGD, consult, SICU, surgery, and ICU. MICU comes and says, admit to us, do the MTP, monitor H&H, ECG by GI. You've already done all these things, obviously, so we'll let you know. Surgery comes and they said, it's non-surgical. We're going to be at the bedside with GI and EGD, continue MTP. All right, so everyone keeps saying MTP, MTP, MTP. What the hell is MTP, right? So, yes?
Why did they choose 10
Why does GI choose 10?
for the hemoglobin goal?
So I think historically, and this is historically, I'm not really sure why, but historically this was the number that they used for cardiology patients. I think the studies were done in cardiology that this was better cardiac mortality. I'm not really sure why GI chose 10 for this particular patient, but I just remember that this was better mortality in cardiac patients. I just don't remember what.
Some literature says 7, some says 9, depends what you're reading. The newer GI literature is pretty clear that 10 should not be your goal. Patients actually do worse when you go till 10, and that's just based on the GI literature. So we should definitely not be choosing the 10 in acute GI. We should be obviously resuscitating, but 10 should no longer be the goal. It's no longer the recommended goal based on the GI literature.
Those are the GI recommendations. So I would have to So this is just definition of massive transfusion protocol. The definition of this is varied depending on what literature you read. But then at the end of the day, it ends up being the same thing. So if you anticipate a patient is going to need greater than 10 units in the first 24 hours, you can call that person that requires massive transfusion. Greater than 4 units in the first hour, some people say greater than 4 units in the first 4 hours is massive transfusion as well. Primarily, this is just a protocol they use so that the blood bank can get the blood ready as soon as possible. Other sources would say greater than 20 units in the first 24 hours. We'll talk a little bit more in detail about the massive transfusion in the different hospitals. So the patient got 4 PRBCs and 4 FFP. So she met massive transfusion protocol. She did get it pretty quickly. She got a femoral cordis placed in the ER. PPI infusion was started, and her repeat hemoglobin after these 4 units was 9.4. Okay, so it looks like she's doing a little bit better. Patients were then transferred to MICU. The MICU course, obviously still hospital day 1. She got a stat EGD in MICU, which showed poor visibility secondary to multiple clots in the esophagus as well as copious amounts of blood. So they couldn't visualize where she was actually bleeding. She then became unstable, blood pressure dropped to SVP of 50s. She was already intubated, so we didn't have to intubate her. She got 6 units of RBCs and FFP and then 2 platelets. So note that this is the remainder of the MTP because they released 10 units they prepared 10 units when you get the first 4. This is the second batch of the MTP that was ordered from the ER. And the patient was transferred to the OR. Surgery was at bedside, they took her to the OR right away. So perioperatively, I read the operative note and just summarized it for you. She had exploratory laparotomy by one of the trauma surgeons, where he says they found multiple bleeding ulcers in the cardia of the stomach, which they had to oversew, put multiple sutures in it, and until the bleeding ceased. He said it was after they suctioned, it just kept bleeding and bleeding. She wasn't on any blood thinners. I forgot. I told you she wasn't on any meds, but she wasn't on any blood thinners. That's important to know. But they oversewed it and transferred her back to SICU. She also got 2 units of red blood cells, FFP, 2 platelets, and cryo while she was in the OR. Okay? So SICU course, this patient had a very prolonged stay in the hospital. She was extubated on post-op day 1. She was okay for the next 4 days, had a rebleed on post-op day 5, and had an episode of hematemesis. EGD on that 5th day showed a clot in the cardia, but no active bleeding, and they couldn't actually dislodge the clot at that time. So she got 2 units of PRBC and 2 FFP, and then they just kept her in SICU. 2 days later, she had another rebleed episode, was re-intubated, and then Blakemore tube was placed by surgery attending, and they only did proximal inflation of the Blakemore tube. IR then had to come in, and they found a left gastric artery pseudoaneurysm, which they analyzed. During this entire process, she also got another MTP. She got 4 units of RBCs and FFPs. Post-op day 9, Blakemore tube was removed. She was extubated, and then they monitored her for the next 5 days in SICU. Didn't have this H&H's was stable. She ended up being downgraded to the floor. Her floor course was pretty unremarkable as well. Stable H&H's the whole time. She ended up being discharged on post-op day 17. Alright, so just a case summary. So this is a 36-year-old female, had a history of upper GI bleed, had a lap band surgery that had some complications to which she had this lap band removed. Comes in in shock, secondary to a massive upper GI bleed. Had ulcers sutured, but then had a rebleed secondary to pseudoaneurysm. So she had a lot of complicating issues that resulted in a lot of her rebleeding issues. She had a prolonged hospital stay. The pseudoaneurysms were embolized by IR. I spoke with the trauma surgeon, and he says he's seen her in clinic twice, and she actually had 2 negative EGGs, i.e. healing ulcers, no signs of bleeding. Just to note that these pseudoaneurysms apparently is a very rare complication of lap band surgery. There's case reports of patients having pseudoaneurysms, so he says, they're probably going to write a case report on this patient. The lap band erosion is actually a pretty common complication, but that wasn't one of her presenting issues, so it wouldn't be anything that affects us. Alright, so if you might have any questions at this stage. No? So I have plenty of questions, right? Like anyone who knows about the case specifically? So I have plenty of questions, right? Yes.
Was there I noticed that the surgery GI was established, was there any thoughts or comment in the documentation about why IR wasn't involved?
So IR was involved later. IR was involved after the second region. Do you mean in the
But anything prior to that, like hospital, because it was like hospital just said that's like
So by the time she didn't bleed. Her first rebleed was in post-op day 5, at which point she'd already been downgraded to the floor. So I think when she rebled on the floor, they tried to manage it, and then when she rebled again, they were like, okay, let's call IR. I don't think there was anything wrong with that.
I wonder why the patient didn't go to the SICU under the care of surgeons for an operative complication that appeared she was gonna need operative management
So-
initially.
Yeah, so, I mean, I guess the way that I presented it sounds like surgery already thought that they might need to take her, but they wanted to give, GI wanted to do the EGD, and I think at that point they thought they might be able to manage it endoscopically. When they realized that they couldn't, then the patient went to OR and then was transferred.
Sally, are you talking about her last removal?
No, I just, there's like known erosive aortoenteric complications from lap pads. That, I just like her bleeding that much, second bleed in a week, made me think that she very likely needs an operation.
Yeah, I mean, we discussed it, part of it was because we knew, like, I spoke to the doctors at the outside hospital, she had known ulcers. So the thinking was that a fistula or some sort of erosive injury was less likely because she had documented ulcers from 2 days ago.
Yes.
It looked like on the timeline that the Blakemore tube was left for 2 days. Is that like how long do you keep?
So thanks for pointing that. We're going to talk about that a little later, but typically they try to take it out as soon as possible. So 48 hours was kind of long, but she had such a serious, like her case was just too complicated for them to take it out too quickly. Usually I think they usually take it out.
And you said it was only inflated proximally, so only the esophageal part was,
Yes.
so basically it just means you can't see the bleeding, but it's just going down.
Well,
They're not tamping
well, they
out.
didn't see any more Atlantic stool after, so we didn't say that it wasn't a bleed, but we're talking about it. Okay, so I had questions. And my questions will sort of align with the discussion topics that we're going to have for this talk. So my first question was, what is hemorrhagic shock, right? This patient is in hemorrhagic shock. I mean, this might be review for a lot of people, but maybe the interns don't know how to define it and how do you manage it in the ER. Kind of went through it through the case, but just to make it pretty clear, how many units of RBCs, FFPs, or platelets should I order? Does it even matter? Like the ratio, does it matter? Are there interventions that we can try other than, just relying on GI or other than just relying on surgery to come and manage these patients? Is something that we could do in the ER while we're waiting for these patients. Okay, so the first question, identify hemorrhagic shock and how do you manage it in the ED? All right, so the definition of shock, right? It's a circulatory abnormality that results in decreased tissue perfusion as well as decreased tissue oxygenation. This is like probably page 6 in the details, right? I try to split up, there's different types of shock, hemorrhagic shock versus or hypovolemic shock, and everything that's non-hemorrhagic. So all the other categories fall in non-hemorrhagic. So your septic shocks, your cardiogenic shock, and your neurologic shock, neurogenic shock. I'm only going to talk about the hemorrhagic shock. Recognition of shock is important. A cold, clammy, tachy patient comes. Don't wait for the heart rate and the lactate to decide that this patient is in shock. This is shock until proven otherwise. If you have a patient that doesn't look quite so obvious, definitely elevated heart rate and increased lactate, which we already talked about. Fever only in like septic patients or maybe trauma patients sometimes. Elevated respiratory rate and decreased blood pressure are definitely under 100, definitely SPP, are definitely signs of shock. Alright, so I have a table here that everybody's going to recognize, which just breaks down the different classes of shock. Class 1 and 2 are, the different classes of shock are characterized by the amount of blood loss. So class 1, anything less than 750 cc's. You can check their vitals as well. You can classify them based on that. Their pulse rates are still normal, and their mental status, they're slightly anxious, but they still look pretty decent. This is probably those dehydrated patients, very dehydrated patients that we see. Second class of hemorrhagic shock, then 750 to 1.5 liters, starting to get a little more significant. Their heart rate starting to increase a little, 100 to 120, and the level of anxiety or mental status started to change a little bit. Class 1 and 2 usually resuscitation would just require crystalloid IV fluids. When you start getting into the higher levels of blood loss, so class 3 would be 1.5 liters to 2 liters. Class 4 is 2 liters, greater than 2 liters. You can see how elevated these patients' heart rates are, and they start to get confused and even lethargic. So our patient was lethargic, and she definitely lost more than 2 liters. So to me, it seems like, you saying the patient's issue is tissue perfusion and oxygenation, so we do definitely need to correct those 2 things before we move on. So class 3 and 4 can get crystalloid, but this is just temporizing while we're waiting for the blood products. So you give them IV fluids while you're waiting for the blood products to come. So, massive transfusion protocol. We obviously work at 2 different hospitals, and the massive transfusion protocols work differently. Downstate actually does not have massive transfusion protocol in place because this was set up initially for trauma patients, and Downstate doesn't really see that many trauma patients. However, if you do get a patient that comes and they need, greater than 4 units of PRBC at the same time, just order it in the computer. Make sure you call the blood bank. Don't forget to fill out the orange card. And then Kings County, thanks to Dr. Legone, this is the flow sheet that's in the MTP policy handbook. Most of these things we kind of already do. Patient shows up with uncontrolled bleeding. You want to get their basic blood work sent off, get the IV O2 monitor, right? The flow of this is somewhat, has actually changed recently, and apparently they're going through new transitions for MTP protocol. So you order it in the computer. I haven't been to county in a few months, and I heard this is something new that you can order it in the computer, and then you call blood bank and tell them that you're ordering MTP, and then you fill out the form. This is the form that you fill out. Make sure you have patient information because they're not going to give it to you without it. Make sure the attending signs it, and according to Dr. Legone, anyone can pick up the blood. Okay? There's multiple questions. And then you just mark which box you want it to go in. Alright, so we've talked about massive transfusion, we've explained what shock is. In my, my own opinion, ED goals of acute upper GI resuscitate definitely is the first thing that we want to do, right? Crystalloid while you're waiting for the blood products. Restricted transfusion of blood products in appropriate ratios. What are appropriate ratios? And then just keep a lookout for DIC. The other thing that, this is what we want to do is stop the bleeder. Stop the bleeder. The things that we could do in the ER is give TXA, this anticoagulant, so like PCC or recombinant factor 7 could be given, EGD, Blakemore tubes, surgical interventions, and then you want to find the bleeder. So basically the 3 things: resuscitate, stop the bleed, and then find the bleed. Finding the bleed is not really anything that we would do. This is something that our consultants would do, but we could definitely play roles in the resuscitated and the stopping the bleeding part. All right, so second question, how many units of RBCs are important, right? This is kind of a hot topic. We just did it in one of the articles in Journal Club. And does it even matter how many units, what the ratio is of PRBCs, FMCs, to platelets? This is one of the first studies actually that started talking about the ratio of blood products in trauma patients. This was by Bogman et al. It was in a military, done in multiple military hospitals. It was a retrospective observational study that included 246 patients that came in with multiple combat trauma, that needed multiple massive transfusion protocol. So what the group did was they randomized the 246 patients into 3 ratios, 1 to 8. So this ratio is FMP to red blood cells. So they put them in 3 groups, the 1 to 8, the 1 to 2.5, and the 1 to 1.4. So the 1 to 1.4 group is actually the high FFP ratio, and this one is the low FFP ratio, this is intermediate. They wanted to see what type of ratios of blood products had the most benefits, and their primary outcome was mortality. So based on this particular study, and I'm summarizing a lot, the mortality was 65% in the 1 to 8 ratio, 34% in the 1 to 2.5, and 19% in the 1 to 1.4. I mean, it's not really hard, it's not rocket science. You can see that the mortality is decreased. And they concluded that mortality was reduced with increasing FFP ratios. But all of these studies have limitations, right? So the limitation of this particular study, because it was, I was going to say back in the 80s, but in 2007, and at a multiple trauma center, these patients got whole blood transfusions at the same time that they got these FFP They also got recombinant factor 7, which sort of muddied the waters. Is it the whole blood that they got before they got the treatment arms, or is it the factor 7 that they got? And also, these are multiple trauma patients, right? They present with very high mortality ratios from their injuries prior to even getting any of the treatment studies. So, there's high mortality to begin with. The second study was done by Holcomb et al. This is actually the same person that did the proper study trial. And this was retrospective review as well. Included 16 trauma centers and had 467 patients who involved in multiple traumas that needed massive transfusion protocol as well. Their mortality, their primary, so they randomized the patients. They tried to narrow the ratios at this point. 1 to less than 2, which was the high FFP ratio, and then the 1 to greater than 2, and then their outcomes were mortality at 6 hours, 24 hours, and at 30 hours. Again, these are just averages of like the three different time frames, and they showed that survival was actually increased to 59.6 in the high FFP ratio group. The secondary outcomes were like decreased hemorrhages, decreased ICU days, and decreased rebleeds, and those were also significantly decreased. So their conclusion was that a 1-to-1 ratio has decreased mortality at 6 hours, 24 hours, and at 24 days. I was a little confused where they got this 1-to-1 ratio, because they only did 1 to less than 0.2. So anything that was like 1 to 1.5, 1 to 1, 1 to 0.5, they just included, and then they did some regression studies to come up with the 1-to-1 ratio. So this is actually the first study that started showing 1-to-1 ratios, even though theirs was determined based on calculations. Another conclusion that this group made, which I thought was a jump, was that they concluded that higher platelet ratios also decrease mortality. This is actually the first study to start talking about it, but they don't actually have a separate platelet to RBC treatment arm. So how can they say this when, whenever they've been transfusing, they're just transfusing platelets randomly. So the platelets were always included when they got the FFP and RBC, but I think they would need to do just a separate arm to include this. So the last study, the third study, is done by someone we know and love, Dr. Z. This was in 2009. It was a retrospective observational review study that included 51 pooled patients from 4 actual articles. So what he did that was different from the first 2 articles, which he actually excluded from the study, was he excluded any patients that got recombinant factor 7 and any patients that got whole blood transfused to them status after their traumatic injuries, which is important because, all of these studies are making these big conclusions, but they have all of these confounding factors. And then he actually decreased the ratios and used a 1 to less than 1.5, which is a little closer to the 1-to-1, and another one, and the other arm was a 1 to greater than 1.5. So the first one would be the high ratio, and the second was the low ratio. And mortality, and then the results that he came up with were actually kind of all over the place. Only one study showed a significant decrease in mortality. 2 studies showed no statistical significance. There were reductions in mortality, but they were not statistically significant, and there were small studies as well. The 2 were, one of the studies had like 110 patients, the other one had 60 patients. So maybe if they increased the number of patients in the studies, that they would gain significance. And then the one study had absolutely no difference at all. So the conclusions that Dr. Z made was that there's not enough evidence to suggest benefit based on just the statistical findings. But then the trend is, the general trend is that increasing FFP and RBC ratios does improve mortality. So maybe we just need better powered studies to make these conclusions. And then as you've noticed, all 3 of the studies we talked about have all been retrospective. So they're all chart reviews, database searches of old articles, just because no one had ever done any randomized control trials until this paper came. This is the paper that we just did in Journal Club, like I said. This was done by the same group, Dr. Holcomb et al. It was a multi-center RCT, the first of its kind, had 680 patients after severe trauma needing multiple transfusions. They were randomized to a 1-to-1 group versus a 1-to-1-to-2. So this is FFP platelets to RBC. And then the outcomes were 24-hour mortality, 30-day mortality, and then secondary outcomes were hemostasis, causes of death, and need for surgical interventions. I was kind of disappointed when I saw the results. The mortality for either of the days, so 24 or 30 days, wasn't decreased at all. I mean, it was decreased, but not significant. But they did have significant increases in hemostasis as well as exsanguination. And hemostasis was actually defined by the surgeons, or IR. And the way they defined hemostasis was if the surgeon during the OR noticed that there was no blood in the stomach, then that was deemed hemostasis, or no blood secondary to the traumatic injuries, then that was hemostasis. And IR just defined it as just a lack of contrast flash. Exsanguination wasn't actually defined in the study, but I mean, exsanguinate regardless. This is the #1 killer of patients with hemorrhagic shock. So if someone says, it improves exsanguination, then I'm with it. And they can prove it, sorry. So the conclusion of the study, like I said, no significant difference in mortality at any of the time frames. Definitely more hemostasis was observed in these papers, and less exsanguination. The limitations are that these patients have very high injury scores from the beginning. So these are patients that, probably wouldn't do well at all. Unclear if FFP versus FFP/platelet combo had a contribution to patients' mortality. So the next direction for this would be, they should definitely do RBC to FFP, and then also like a separate arm for platelets, because we don't know exactly, what role platelets are playing in this. So is this relevant to our practice? I don't know. What do you guys think?
For us?
Yes.
So one comment about the proper study I will make is that they actually went back and they kind of looked at data again, and they kind of redefined their mortality benefit. Yes, at 24 hours, really nothing statistically significant, but when they went back and looked at it and they looked at the 3 hours, that they did show was very, very, it was a statistically significant change in mortality. And truthfully, I think that the 24-hour and 30-day marker, when you're talking about these types of transfusions, kind of allows for kind of survival bias, and certain other things to be introduced. I think this study was more aimed at kind of initially treating that exsanguinating trauma patient, and when you looked at the first few hours, which is when most people exsanguinate, right? At 24 hours is because now they have trolley or SIRS, or they now have something else going on with it, or at 30 days they have sepsis and things like that. Those are the people that actually made it through their injuries to 24 hours and 30 days. But when you actually go back and look at the data, 3 hours, 6 hours in, more people were surviving with the higher ratios. So I think that this is something that does apply to us in the emergency room.
I definitely agree. Mortality, they showed a trend to increase, so that's a good sign. But I mean, hemostasis is something we are worried about in the ER, right? Like, these are the things that we can actually do something about to prevent examination. So for me, this was relevant for my practice. I think this is something that we could probably use, and it is actually being used in our massive transfusion protocol, because we are 1-to-1 in Kings County. So proper ratios, do we do it properly? So it was 1-to-1, right? In the ER, we gave 1-to-1. We didn't give any platelets, but we were in there. NICU, I don't know what this is, 1 to 2 to 3. In SICU, they gave 1-to-1, and they topped it and gave cryo. So the total number of blood product that this patient got 18 PRBC, 16 FFP, and 4 platelets. So it's actually like a 1-to-1 to 0.25 ratio that we ended up doing for this patient. And she's like,
So platelets give like 6 packets.
So platelets 6 units to a pack.
so she was
So
like,
that was pretty
Yeah.
close.
so 1-to-1 and a half.
Yeah.
No.
And that's why usually in the ED they're not down there long enough,
Well, this patient was out of the ER.
which is a good thing.
Alright, so we've had comments already. So the third question now is, can we actually stop the bleeding lead stopping typically is done by our consultants, right? The EG, they'll take the patient, endoscopy visualize the esophageal gastric bleed, cauterize it, and stop the bleeding. In the OR, they take it for X-lab, they can overstow the ulcers, IR, and do arteriograms and embolize these. So what's our role, right? We have the Blakemore tube, which is like a balloon tamponade kind of system, was developed way back in the 1950s, but hasn't really changed much since then. So this is an esophageal, this is a tube, this is esophageal balloon, and then this is the gastric balloon. And then I put this picture here to just show you what it looks like after it's been placed. I told you the patient only had proximal inflation, and they thought that that sort of seized the fluid bleeding she was having. The gastric balloon actually wasn't inflated in this patient, and usually just kind of sits right here on the part of the stomach. All right, so we're going to use the Blakemore tube. We need to know what the indications for the Blakemore tube are. It's unlike, usually it's very rare in this type of patient to use a Blakemore tube. Typically, the patients that get Blakemore tubes are variceal bleeders, patients that have, if you don't have EGD at your hospital, and you need to do something while you're waiting for GI to come, you can put a Blakemore tube. And then in this case, which has only been, where Blakemore's only been used in case reports, you can actually use Blakemore tubes if the patient's bleed is refractory to everything. So this patient got EGD multiple times, went to the OR. The next step was to put a Blakemore and see if IR can do something about it. So she got it and helped. Complications of Blakemore tubes, and aspiration is one of them, just based on how you need to get this thing in. Asphyxiation again, and just esophageal rupture and perforation. Like you have to put it through the pharynx, so you can easily rupture or perforate this. So like Sally and Shabbat had asked, typically they try to keep these in as short as possible. And this patient had it in only for 2 days. The next thing.
Just a quick comment on Blakemore. You mentioned it. I don't know why they did a Blakemore on this patient. The concept behind the Blakemore tube is to actually tamponade the bleeding. And the idea is with variceal bleeds, most of the varices are going to be kind of in the GE junction area. So when you inflate that gastric balloon and you pull on it, which is what you need to do, just inflating the balloon is not going to help. They actually need traction on that balloon, so it needs to be connected to something else. And you're going to actually just push down on those variceal bleeds and actually tamponade the bleeding. So, and then the esophageal, so there's esophageal varices as well. You're always going to do the gastric balloon first, and then the bleeding doesn't stop. So if somebody has a gastric ulcer, blowing up a balloon in their stomach is probably not going to stop their bleeding, because the balloon is not the size of the stomach.
So my understanding for this patient, she had the Blakemore was actually helped with the pseudoaneurysm. I think just by the proximity, I went to try to look at anatomy to see exactly where this left gastric artery was and where the pseudoaneurysm was. I think maybe that's what my postulation was, and I tried to ask him, and he was like, I don't know why it worked. So, I don't know.
Josh is partly correct. The balloon can tamp down the bleeding, but the main reason to pull a traction on it is because remember the varices form the high pressure in the liver. So if you can put a very large balloon in the stomach and pull it up, it'll block the portal pressure coming back from the liver and the stomach up into the esophagus. That's the main region for the stomach balloon. The second balloon, the esophageal balloon, doesn't have it on it, but the stomach balloon stops the back pressure of the high pressure portal system into the varices.
One more practical way to stop. To place it, it's actually very, very
Super hard. It's not as hard as an NG tube.
You have to tie it to an NG tube to place it. So you have to actually tie it, like piggyback on top of an NG tube and pass both tubes in.
So usually what I do if they're intubated is I'll put my fingers down in the esophagus and I'll pass it between my fingers. And I can feel it going down and I know it's going into the right place. But they're very soft. They're way harder to place than an NG tube is. Really difficult.
Okay, so just the last one we're going to talk about, TXA and upper GID. There's a big thing of okay. So this is a copy review which I actually read. I thought we were talking about this on Saturday. It was a meta-analysis. So the reason we wanted to discuss this was just because in multiple trauma, even on our massive transfusion protocol, we can actually give TXA, and we've actually been giving TXA. So this Cochrane review just went over whether TXA has a role in upper GID, since they are experiencing massive, they're in hemorrhagic shock as well. I want to see if there was a difference. So the methods, it was a database searches of 7 randomized control studies. They actually looked at about 1,600 patients who were either suspected of having an upper GI bleed or had a confirmed upper GI bleed by endoscopy. The patients were then placed into 3 treatment arms, so TXA versus placebo, TXA versus just our generic anti-ulcer medications, so cimetidine and lansoprazole, and those are 2 separate ones. Their outcomes were primary mortality improvements, or secondary outcomes were hemostasis, risk of rebleed, as well as need for surgical interventions even after they got the TXA. And the results of this were, encouraging, but not really that great. So TXA versus placebo showed risk reduction in mortality. That was actually significant. However, no significant reduction in rebleeds and mortality for the TXA versus placebo. Now, the TXA versus cimetidine and the TXA versus lansoprazole had very slightly increased, but not really significant. If you look at the confidence intervals, they're all over the place. This one is even just ridiculous. I thought that so the conclusions of the study based off just the general conclusions based on just it was a very big review and they looked at multiple different arms. We were only concerned with the TXA versus placebo. They concluded that it does decrease mortality, but rebleeding is generally decreased but not significant. Same thing with the TXA versus cimetidine, there's no significant difference. What I thought was interesting was we never really give, would we be in a situation where we would just give TXA and not give the cimetidine and lansoprazole? So the study actually had a treatment arm where TXA and cimetidine and TXA and lansoprazole was given versus placebo, and there's still no difference either, whether you combine it, whether you separate it, there's no difference. So, like I said, limitations of the study, there were multiple studies. The experimental designs of the studies were very, very different, and they did their best to try to homogenize it to come up with some conclusions. Rebleeding criteria, which I think is important in hospital settings, was defined very differently in all of the studies. Like I said, there's very high heterogeneity of the studies. I think just because there is a trend to increase, most likely, increasing the number of studies or at least having a few more randomized control studies might actually increase the benefits of the study. Mortality is decreased, so this is a good sign, but rebleeding and hemostasis are things that we care about as well in the ER. Should we consider this in our practice? It's used in the MTP protocol for trauma. They just give 1 gram, I think, via IV push. So maybe, they definitely wrote that there was no harm to giving TXA. So if you're curious, you can try it. But, I think they need more studies to come up with better...
I would 100% give it. I think, especially in a young patient like this, the risk of getting is super low. They've been using, TXA has been being used specifically in these scenarios. GI bleeds, not just trauma, GI bleeds, GYN bleeds, in Europe and internationally for 20 years. And I think there's a ton of case reports in the literature. There's not a lot of RCTs maybe, and I think your risk of giving it is low. So my approach is anybody who's getting a massive protocol, whether it's trauma or not, I would probably give it TXA.
It's part of the protocol, so they will get money pushback to get it. Alright, so take home, my take home from this talk. First, our transfusion goals are 1 to 1 to 1. So far, this is what our MTP says, protocol here at Kings County. But, a lot of the studies are starting to lean towards this. The trend is increased and improves hemostasis. So, no significant mortality yet for this rate. But, more studies to come, most likely mortality will be reached soon. Get definitive care personnel on board soon. In this patient, this was a very, very, very sick woman. I don't think we could have kept transfusing her, but she had bigger problems that we could have dealt with in the ER, and the team did a good job taking care of her. MTP protocol, Kings County, order it, call it in, and then bring the form. If nothing else works, you can Last time I saw it was in the bottom drawer in the trauma bay, but
It's
someone
sitting on top of the desk.
Someone
It's in
told me.
Yeah,
It's in the back,
Yeah.
it's in the back corner. Yeah,
Okay,
like where the-
I pulled it out yesterday, so it's on the desk.
Yeah, it's like,
Oh,
why is this here?
It's on the desk. It's in CCT, and someone should be able to find it.
Okay, there's a second one. If you are looking at the back wall in trauma 1, look to the right. There's the short gray cart with the refill of the airway cart with basket drawers. It is in a second basket drawer. I saw 2 there yesterday.
So we do have it. It's in CCT,
It's
trauma
there.
bay, it's in the trauma bay. And then TXA reduces mortality. I think there's no harm in using it, even though there's no significant there's mortality benefits, so there's no harm in using it, and we should use it with our ENT. These are my references, and I'm done.
I want to add a couple more points on upper GI bleeds. GI bleeds in general. Most of these bleeds stop on their own, and they really don't need emergent EKG. Like, these patients really need good resuscitation, and good resuscitation is what's going to save these people's lives. So calling GI and saying you have to come to the hospital right now and do this endoscopy, that's not actually the guidelines. That's not what's going to save these patients' lives. Good resuscitation by us is going to save these lives, because most of these ulcers, they stop bleeding for a period of time, and then GI can go in, do the EGD, and do usually either inject or clip or cauterize. They'll do a few of those things, and will really make a difference. So the only time that GI is really going to probably make a huge difference in the acute bleeding setting is with varices, because they can band those. But otherwise, if it's like an ulcer that's bleeding, this patient's a little bit different, kind of a strange case. But most of those ulcers, they're not going to be able to find it when it's actively bleeding. So having GI come in to stick a scope in an unstable patient is probably not worth it. It's really just good resuscitation, and then waiting to go in there and do the procedure. Also, the transfusion till 10, those guidelines are old, and the most recent guidelines is usually till about 7. If it's a high-risk patient, like a cardiac patient, then sometimes they say 9. The article to read on that is in the New England Journal from, I just looked it up, it's 2013, and I can send it out to Sally to share with you sometime.
But if they're actively bleeding, forget
Right,
forget
this is like, if you're bleeding actively, just resuscitate, don't worry what their hemoglobin is, because whatever you're getting is not accurate.
Shout out to Save of the Month, Clinical Monster. Shabana we recognized clinically a tension pneumothorax, needle